So good day, I'm Billy, and I'm a health data epidemiologist at the University of Oxford, the Netfield Department Population Health, which is the NDPH. And the study I'm presenting today is part of my PhD research back in Manchester, working with Professor Ted Winston, and also conducted in collaboration with the UK HSA, the UK Health Security Agency, utilizing the Open Safely platform. So we looked at the clinical and health inequality risk factors for non-COVID related sepsis during the pandemic. So let's turn our focus to sepsis, a serious global health problem. As sepsis is not just an infection, it happens when an infection causes the immune system to overreact it and leading to organ damage that can be life-threatening. So it is not only a health issue, but also affects the economy and communities worldwide. So preventing infections both in communities and hospitals is key. These steps are our best way to stop infection from turning into sepsis. In 2017, about 49 million people had sepsis and 11 million ended up with deaths because of it. So seeing how big the problem is, the WHO has asked the countries to improve their how they handle sepsis. This includes recognizing it earlier, keep good records, and taking steps to prevent and treat it properly. So regarding of the health inequality, the NHS England has introduced. All right. Sorry about that. So regarding of the health inequality, the NHS England has introduced the Core 20+5 to tackle big differences in health outcome. So this plan focuses on three main aspects, the Core 20, the Plus, and the 5. So the Core 20 focuses on improving care for people living in the poorest areas. And the Plus part looks at groups with worse health outcomes than average, like ethnic minorities, people with learning disability, or those at higher risk of serious disease. And finally, the 5. The 5 shows a focus on improving results in 5 important areas of healthcare. And before we really jump into this study, we conduct a literature review, and our finding shows that there aren't many studies looking at the link between health inequalities and sepsis outcome. The research that does exist is scattered and doesn't use a clear definition of health inequality. This makes it clear that we don't fully understand how social and economic differences affect how sepsis is recognized and treated, especially across the country. And also, additionally, as we all know, the COVID-19 pandemic gave another complexity on these already critical issues. And all of this lead to our research focus, which is look at what is linked between health inequality and clinical risk factor and sepsis, and how has that changed during the pandemic. So there's 3 main objectives of this study. First, look at the trends before and during after the pandemic about the sepsis risk, and also evaluate the health inequality and clinical factors and the association between that and sepsis outcome that include sepsis incidence and 30 days mortality. So our study used data from Open Safely, assessing primary care record via TPP, and we analyzed about 23.4 million patient records, and that data was linked to ONS death record and SGSS for COVID diagnosis, and also SUS for secondary care information. And the study included the records from January 2019 to June 2022. We identified sepsis patient with ICD-10 code and focus on their first sepsis episode because we're only interested in look at those new sepsis cases. And we kind of define our primary outcome of the non-COVID related sepsis during admission, and secondary outcome as 30 days mortality post-sepsis diagnosis, and the exposure that we're looking at include those health inequality risk factor, deprivation, clinical factors, etc. And there's also another thing that I want to mention is the community-acquired sepsis was defined as a patient who had a sepsis diagnosis within the first 2 days of the hospital admission. And if a patient's sepsis episode started more than 2 days after the admission, it was categorized as hospital-acquired sepsis. And we got missing data in BMI and smoking history and anesthesia. We conducted many different ways as sensitivity analysis, including multiple imputation and complete case analysis. And here are the results. So during the study period, more than 225,000 of cases were eligible for non-COVID-19 sepsis, with 80% of being community-acquired and 20% being hospital-acquired. And when we look at the incident trends, the monthly hospital rates dropped it from 0.3 per 1,000 registered person in February 2020 to 0.1 in April 2020. And the rate fluctuates to April 2021 and then remains stable till the end of the study. So stable, I mean like slightly decrease and with the kind of seasonal trend that go up and down. And additionally, the least deprived quintile had the lowest risk of developing sepsis across all periods. And in our association analysis, we found that the individual living in the most deprived quintile kind of have the highest odds of developing sepsis with an odds ratio of 1.8. And also we found that there's a variation in ethnicity and also BMI. We found patients living with obesity or underweight have a higher risk, higher odds of developing sepsis, and also smoking as well. And for clinical risk factor, before that, there's also care home status is kind of a higher risk group, and also for clinical risk factor like chronic kidney disease and kidney replacement therapy, and also diabetes, especially those not controlled, have a higher odds of developing sepsis. And also here's the cancer and also chronic liver disease, other neurological disease, and also autoimmune disease, etc., and learning disability as well. And we also look at the number of period antibiotics prescriptions, so between 1 year plus 6 weeks to 6 weeks before the index date, which is the sepsis diagnosis date. And we found that patients with more than 3 antibiotics prescriptions within the last year had an adjusted odds ratio of 3.38. So, and also a similar pattern was seen in the mortality analysis, where people with lower socioeconomic status had a higher death rate. And to run up, this study shows that living in poverty and have certain health problems greatly increase the odds of developing sepsis, non-COVID-19 sepsis. And the incidence of sepsis was affected by the pandemic, but the association that I mentioned earlier remained kind of consistent. So this study helped us learn more about sepsis during the pandemic and also its weather effect. And it shows that improving how we prevent sepsis could make a big difference. And adding information about chronic disease and also those health inequality risk factors like deprivation, severe mental health into the risk prediction model may potentially lead to a better outcome. So also using the right antibiotic more effectively could help lower sepsis risk. This aligns with the work our team in Manchester have been working on, developing a knowledge support system to assist the clinician in making better antibiotic prescribing decision. And furthermore, this work on sepsis contributes to this year's EHPAUR report, which is the English surveillance program for antimicrobial utilization and resistance from the UKHSA. And here's the link for the paper. Feel free to scan the QR code and get more information that was published on the Lancet Clinical Medicine. And thank you very much.